Hello, and welcome to the Health Equity Book Series. Thank you so much for joining us. My name is Elizabeth Hart. I am the director of the the Office of Faith-Based and Community Engagement at the Tennessee Department of Health that sits within the Division of Health Disparities Elimination. Welcome, welcome, welcome. This is the final event of our inaugural round of our Health Equity Book Series. We certainly hope everyone has enjoyed the book series so far. We've had some incredible authors. And I want to remind everyone once again that this Health Equities book series was brought to you by, again, the Division of Health Disparities Elimination. That includes my office, which is the Office of Faith-Based and Community Engagement, as well as the Office of Minority Health and the Office of Rural Health and Rural Health Access. Also want to thank our partners in the Office of Primary Prevention and our Health Equity Advisory Team, all part of the Tennessee Department of Health. Again, welcome to this final final event of our inaugural round of our Health Equity Book Series. A couple of housekeeping reminders, as always. We encourage you to type your questions into the chat. We will get to them during our discussion today. If you are not already a member of the Tennessee Health Disparities Task Force, we'd love for you to join. We have 4 focus areas and priorities focusing on chronic disease, mental health, environmental health and justice, and infectious diseases. If you are interested in joining the Health Disparities Task Force, we encourage you to email tdh.ofbce@tn.gov. Again, that email address is tdh.ofbce@tn.gov. To learn more about the health equity work that we're doing at the Tennessee Department of Health and the Health Disparities Task Force and so many other projects within the Division of Health Disparities Elimination, I encourage you to go to our website, and that is www.healthdisparities.tn.com. Again, www.healthdisparities.tn.com. When you click on the Health Equity tab on the website, you'll find all of the recordings from this year's Health Equity book series. And now, without any further ado, I want to introduce our author for today, Dr. Damon Tweedy. Dr. Damon Tweedy is a graduate of Duke University School of Medicine. He is an associate professor of psychiatry at Duke University School of Medicine and staff physician at the Durham Veterans Affairs Health System. He has published articles about race and medicine in the New York Times, Washington Post, Chicago Tribune, and Raleigh News and Observer, as well as in various medical journals. He lives outside of Raleigh-Durham, North Carolina with his family. And of course, we are talking today about his book, this one right here, Black Man in a White Coat, A Doctor's Reflections on Race and Medicine. If you don't already have this book, we encourage you to pick it up on any of your favorite platforms and read this book even after we have this conversation today. So again, I want to welcome Dr. Damon Tweedy. Welcome, Dr. Tweedy.
Yeah, thank you. It's a pleasure. And thank you everyone who's in attendance as well. That's always fun.
So can you tell us just a little bit about who you are and your life's work and really kind of why you chose initially to write this book?
Yeah, you want my whole life story. So let's see. So I guess I'll get the quick version. So I'm from Maryland. Along with my brother and I were first in the family to go to college in our family. So first generation. I went to college at the University of Maryland, Baltimore County, UMBC. Went to medical school at Duke. And so that's kind of where the book sort of picks up in 1996. And so that was 25 years ago plus now. And so I'm still at Duke. And today I actually have what I would consider like kind of 3 sort of part-time jobs, for lack of a better way to explain it. So on one hand, you mentioned the VA. So I'm a psychiatrist by training. That's always a discussion. I'm sure that topic will come up. So I'm a psychiatrist by training. So I do part-time at the VA hospital as a psychiatrist. I supervise a team of mental health providers, which includes nurses, nurse practitioners, social workers, psychologists, and we work in primary care medical clinics. And so one of my big passions is how do we interface primary care, general medicine with mental health, because right now, for a long time, they've been very separate, and that's caused all sorts of problems. So that's one job. A second job I have is I'm an associate professor at Duke, and so I teach several medical student courses. One is like a kind of introduction to ethics and bioethics and these sorts of things. But the other course I'm involved with is basically teaching psychiatry for the future doctor who will not be a psychiatrist. So kind of like psychiatry for the non-psychiatrists. Again, it's a big issue. Doctors from all fields see mental health people with mental health problems, but they do we get a pretty poor job of being educated in medical school and beyond when we face with people in the real world who have mental health issues if we're not trained in the field. So that's really a passion of mine. And then the third part-time job is writing, so and speaking. So I wrote that book. It's 2015. It's a long time ago. Given a lot of talks since then, but I'm also working actively, finally, on a second book. This book will be exploring a lot of the themes of mental health and its intersection with general medicine, which I was discussing earlier, but a very similar format, a lot of memoir, a lot of that, but also integrating that with sort of data and what I've learned along the way. So that should hopefully be out, if not in 2023, then certainly by 2024, because I'm mostly done with it. So I'm looking forward to that getting out into the world and having more conversations.
So you talked about that your book that you're writing currently that'll come out in a year or two, but can you tell us, like, how did writing this book, did it
Yeah.
change how you practice medicine? What influence did it have on you and the way that you practice medicine?
Oh yeah, you did ask if why I wrote the book. So yeah, I guess I had to break it up a little bit. Um, yeah, so let me just tell you this. So when I went to medical school, so during the 4 years of medical school, we had basically one afternoon in a 4-year curriculum where there was any opportunity to discuss racial issues at all. And that was like in a small group setting. So you only kind of knew what your small group was going on. You didn't know what the larger class kind of, so it was really, really sort of very limited. And I always like to joke now, well, if I'd been sick that day, if anyone else was sick that day, then there's really no opportunity to discuss race in a 4-year curriculum, right? And so you think about, but that went against everything I was seeing in the clinical setting. So a place like, Duke, which is in Durham, North Carolina, states in the South obviously have a large black population from historical reasons. And North Carolina is about 20 something percent black. Durham is about 40% black. And so you would see, so you see large numbers of black patients coming through these clinics, and there'd be sort of this disconnect between sort of like what I learned about in the classroom and kind of what I was seeing, in the real world, right? So because in the classroom, they were telling us that, people who they told us that this disease is more common among black people and that disease and this disease and that disease, right? You hear that a lot, but there wasn't any context to it. These things that we talk about now, social determinants of health and social drivers of health, whatever you want to describe them as, that language wasn't really around during that time, and it was really hard to try to get a grasp and understanding of things. So how I came at the book was really trying to. I didn't start with the idea I was going to write a book. I started with the idea of just sort of writing my experiences to sort of process what I was going through. And so I have this old computer. I've got these brand new laptops back then. They're like 50 pounds, there's, so outdated now. I still have it. And I was just taking notes based on experiences that I would have, whether it was in the classroom or something happened in the hospital. And so I started with very modest expectations. I was writing like, uh, some stuff like in a student journal, and then it kind of gradually, slowly built up into something else over many, many years. So I didn't start with the idea that I was writing a book, but what I did find as I started to write more and more was that other people weren't writing about it and had written about it. And I felt like, man, this is something that's really important, and why isn't this out there in the space, right? And so that sort of kind of pushed me forward to sort of, spend the long late nights, writing the book, because I felt like there was something. I kind of wish that this is something I could have written or read myself when I was a younger person, to say, well, this is the kind of things you might go through. This is what you might need to do, this situation, that situation, just so people can have a better understanding of things. I think that was a really important part of my motivation in writing the book, was just sort of trying to get a sense of writing a letter to my younger self kind of thing, And so I think that was a lot of what motivated me to write the book. I do want to say, but I'll let you, I do want to say though, before I forget, that things changed quite a bit
Mhm.
in some ways, because when I first started trying to write in this subject 15 years ago, 20 years ago, maybe 15 years ago or so, when I was still in my training, a lot of those medical journals that I've now since published in were very not interested in publishing essays about race in medicine. One editor at a really prominent medical journal told me, he said, quote, we only publish material that is of importance to leaders in academic medicine. Like he actually said that to me. So he wasn't even commenting on the quality of my writing or what I was saying. He was saying this topic is not important. And you think about academic medical journals really setting the agenda, so they determine what's important in many ways to what what we teach, what we study.
Yeah.
If you say it's not important, then all those things are kind of off the table. And so that was just the environment, in many places 15 years ago. And so just something to think about for where we were then to where we're trying to become today.
Right, absolutely. Great point. And we're going to get to that later in a couple of our questions. Just as a reminder for those that are on the call, feel free to drop your questions into the chat. We will certainly get to those throughout the hour. So you talked about the book and the reasons why you decided to write the book. And for those who have read it, and I have read it, it's a phenomenal book. You weave your own story into the narrative. How did it feel to share such personal details about your life with the world?
Initially I didn't want to do that. So initially, my initial plan for the book was just to write sort of a more, you might call it a dry or academic book about disparities and what I'd sort of seen from that perspective, strictly from the patient perspective. Now, there's clearly a lot of that in the book already that's still there. But I felt like, in some ways, I felt like there was the reader would, I guess from my standpoint, would lack some authenticity because they didn't know where I was coming from. Like, so
Mhm.
maybe they wouldn't understand how I perceived the situation the way that I did if they didn't understand a little bit about me and my own journey. So I felt like there was like these sort of two stories. I also thought that not only were there stories to tell about this experience of Black people in the healthcare system as patients or your consumers, whatever term you want to use, but also as those of us like myself who are providers coming through the system and our own challenges. And so I thought there was something to be told there as well. So that's sort of how it kind of came together. I didn't think that I was going to do that initially. It's really weird because, I never had social media accounts before then. I have them now. I don't use them very much because I'm not actually not a, it's really weird because like this disconnect. Because on one hand, I'm a really private person. I don't like to, share a whole bunch of details about myself. I'm kind of introverted. Yet I've written this book that people can read and they can learn about me. It's a really weird disconnect. I'm a psychiatrist, but I haven't figured it out yet.
I was going to say
So
there's quite a few details about yourself in the book.
yeah, yeah. But it's weird because people say, "Oh, yeah, I know you." When people come to me and they'll say, "I feel like I know you already." Um, yeah, but I think it gives it more authenticity so people can understand. Not only the other thing I would say about that is once I made the decision to write about myself, I've read a lot of books. You read biographies, or I guess autobiographies, and there's a sense that people sort of like gloss over their shortcomings and they just make themselves seem like they're just
Mhm.
the greatest thing ever in every single way. I didn't think that was helpful. I wanted to show my own limitations because the book, so I don't always come across as the most ideal person. And I think that's useful because I think we all have our own flaws and limitations. And I guess I wanted readers, particularly those in the healthcare field, to be able to embrace and accept their own limitations and try and do better. So I think that was a big part of how I approached writing about myself.
Thank you for that. So now we're going to get into some of the nitty gritty in the book. And we know currently in 2022 that health disparities continue to exist due in part to race. And that's a good portion of what your book is about. And you document this throughout your book. And of course, you wrote this, as you mentioned, back in 2015. At the time, what were the most shocking and startling statistics that you found while you were both researching and then writing the book?
I don't know if I can say there's any one statistic. I guess the bigger point that I noticed is how much I learned along the way doing this. So like, intuitively as a Black person in America who grew up in a sort of lower middle class, working class Black family, I kind of knew a little bit of stuff. Like you knew that, you hear that Black people had higher rates of diabetes in the family or high blood pressure. You'd hear this sort of stuff, or maybe even life expectancy is a little bit lower. But I mean, there's so much I didn't know, right? And so one thing I learned is that this really transcends every area of medicine. Like, we hear a lot about maternal mortality, and that's really important, and that's continuing to be an issue. But you name any clinical specialty where patients and doctors are interfacing, and you're going to find different problems in this sort of way. But what I think what's striking now is that I think a lot of times now it's easy nowadays to know that. So you can you can get online, you can Google this, Google that, and you're going to get more than you can ever even read, right?
Mhm.
Um, but when I started, think about starting med school in 1996, there was no internet really, not really one to speak of. Um, I didn't know any of this stuff. So like, in some ways it was like a learning thing. Like people assume that you know all this stuff, but there's so much I didn't know. Again, I knew a few details, but there's so many things that I learned along the way. And so, we hear a lot about, for instance, we hear a lot about the Tuskegee syphilis study and about how the legacy of that and how that whole and sort of how that's informing a lot of issues around Black people in the healthcare system and mistrust. One thing I learned is that that's just one little small part. It's a horrible chapter in history, but it's one small part of a much larger history. There are other things that I learned, other things that I think are less well known that I actually find um, striking. There's a something that's getting more attention now. There was a dermatologist at the University of Pennsylvania, and he had been doing these experiments at a prison during that same period as Tuskegee. He ended up making lots and lots of money. Um, and it's like, well, people don't even know about that. And it's interesting how, so I guess my point is that not only did I learn about other sort of larger studies, but I also learned more about that there's this much larger oral history, right, of other people who describe their own experiences with the healthcare system. And a lot of those oral histories aren't written by doctors. They're written by people in the communities. They're written by people in sort of, academic type people in public health, social work. And so I think with this book helped me, the researching the book helped me expand my horizons because I think medicine has a tendency to be, doctors in particular, to sort of think about themselves as having the most knowledge about everything, which is very unfortunate because there's a lot that we can learn from other disciplines. And I think I learned that a lot along the way. So I wouldn't say there's any one data point. I would say it's just really the whole field kind of opened up to me in a way that, and it also reminded me of how miseducated I'd been all
Yeah,
along. So I think those are sort of the bigger lessons.
absolutely. Thank you for that. So the American Public Association declared in 2020 that racism is a public health issue. And we know a variety of factors create toxic stress and intergenerational trauma that cause mental and physical health issues. So it's kind of a two-part question. What do you see in the medical system currently which perpetuates these health disparities? And number two, what actions can we take to remove these inequities? And as we spoke prior to coming on the event, we have our health disparities task force is a conglomerate of so many different folks and industries, from the public health field to our clinics, our hospital systems, faith-based and nonprofit organizations. So we are all working together to reduce health disparities. And so I'm sure everyone on the call and those that are watching the replay would be interested to know your opinion on what actions we can take to remove those inequities.
Sure. So I guess just to start with the first part, because I may have to pick up the other part later. What perpetuates it? I mean, so one obvious issue is because a lot of these issues are sort of intertwined with socioeconomic, some people might call class, this idea of like education and access to care. And so all those things in a society that sort of perpetuate, disparities there are going to certainly show up in the healthcare world. That wasn't, I mean, that seems common sense now, but it was, again, I don't think a lot of doctors were educated with that understanding.
Mhm.
So I think that, so clearly that perpetuates it. Another thing that perpetuates it is our healthcare system, or maybe if you want to call it a healthcare system, our sense of sort of like the way it's disjointed, right?
Mhm.
In the way that there's such, and it's such fragmented, and that continues to sort of result in different kinds of disparities in terms of who can get care in this setting or who can get care in that setting. And so, and also it impedes our ability to sort of kind of track, like what are the disparities and what are they actually like? Because there's so many different systems of care, and I think that all those things very much make it difficult. Because I think just the other day, we were doing something within our own VA system to try and track. It's been a long time now, but just tracking sort of like who are the people that are coming to our particular VA hospital and some of our clinics in the outside areas of North Carolina, and just how difficult it was to sort of put that into some comprehensive uh, to get that data was difficult, even in our system. So it's only so much more difficult in the outside system that's outside of like a VA health system so I think that's one of the huge problems. Of course, the perpetual disparities between, education and these things are going to continue to sort of make everything worse. Um, yeah, in our sense of making healthcare, the way in which healthcare has been politicized and continues to be politicized also impedes our progress. It's always been, there are things in life that are always going to be political. I understand why it's political in the sense of money, but it's just like, you come to a clinic and every day you're seeing people with different sorts of political beliefs, and they're still, these problems don't discriminate in any way when it comes to that. And so it's always disheartening to think about how we continue to politicize that. Some of our southern states, um, Medicaid is not a panacea, but certainly, there's several states in the South have been kind of resistant to sort of incorporate that or expand it, and that's limited access to care for certain people. So there's just so many different things that are happening that can perpetuate, our thing. So what's getting better? one thing that's getting better, because I don't want to just paint a horrible picture, right? What's getting better, I think education awareness for doctors and medical providers who are going through, not just doctors, but like physical therapists, social workers, the whole realm of providers. They're getting more knowledge base about these issues. I can't tell you how different it is to sort of be me as a med student and have an afternoon in 4 years. And now to see students have like, several months of coursework. And not only just coursework, but having these topics integrated into their other general education throughout, and how important that is to help them as they begin to see patients and then think about how to change things. And I think that the other part that really encouraged to me is that a lot of this change has been initiated by people who are newer to the field, so like students and young doctors. And I think that's really bodes well for the future, that we have people
Mhm.
who are coming into medical school and other health professions with this sort of social this desire for social justice and really being concerted efforts to improve things, because without that framework, you can't really begin to design interventions that are really going to be able to sort of make a real difference. So I think that's my thing I'm kind of most encouraged about. It's just a broader embrace of this topic among students and people further up the chain as we go up.
Do you have any advice, kind of sticking with that question a little bit, for our public health professionals that are perhaps watching this video, what they can be doing in their clinics or in their program areas that are outside of seeing patients the way that a provider like yourself would see?
Yeah, I think we need more separate. I think we need less of the siloed sort of thing, right? So, I didn't. No, I know some medical schools have schools of public health and different
Mhm.
sorts of global health programs. I feel like sometimes there's not enough way in which those things are sort of blended in together, and it feels like people are doing separate things, and it feels like, well, I'm doing this thing in the lab, but how does it connect to real life, right? So I think there's really, we need to find just more and more opportunities to sort of make that just the default rather than the sort of the exception. So I think that's something I think is really important, because I think it's really valuable. Like, if you'd asked me when I was in med school, like public health, I mean, you have some understanding, about vaccines and sort of those, that kind of stuff for children, but like it was hard to sort of put your finger and understand it. So I think the more we can make it sort of more, practical and integrated. So that's not just the fault of you guys. That's obviously the fault of our end as well. But I think more that we can sort of make things practical, and integrated in that way, the more we can sort of, kind of move forward with interventions. I mean, I think those are the best things when people can bring different expertise.
Absolutely.
Yeah.
And I'm sure all the public health professionals that are watching this will agree with you on that one. I want to jump a little bit to chapter 6. So
Sure.
you talked a little bit about an incident and an interaction that you had with a fellow physician when you yourself were getting some treatment or seeking treatment.
Hmm.
So you were describing that interaction when you went to the urgent care for
Hmm.
knee pain.
Hmm.
And the physician that you saw, didn't actually examine your knee
Hmm.
until you disclosed that you were also a physician. And I want to read a quote that you had in the book. You said, quote, "I couldn't get out of my mind how I'd been treated as two entirely different patients. Damon Tweedy, the unknown Black man, dressed like he was about to mow the lawn, couldn't get the doctor to look him in the eye or touch him. And then Damon Tweedy, MD, was worthy of personal first class service." Can you tell us a little bit about that particular experience and how it made you feel in the moment, but also how providers that are watching this conversation we're having today, how they can ensure they don't make that same mistake?
Yeah, and again, yeah, I come at this as someone who's done some version of that, not that specifically with race, but in other versions of that with other people myself. And so I come at this not from a lens of judgment, but from just a lens of like, it's something that's an issue we have to find a way to sort of to deal with. So, when we talk about health disparities, we mostly talked about like structural factors, system things at the sort of the higher level, which are of course very important. There's also the doctor patient level, like how are doctors and patients sort of interfacing. What is the level of sort of engagement that they have? And so in this particular case, it's just striking, right? This idea of like, what do people see so I encourage the people in healthcare who see patients, like, what do you see when you see this person come to your room? Like, what images, what have you sort of learned? What have you internalized over your lifetime, or in your other early experiences? And what do you see? So if I'm not in a white coat, I'm not in a suit and tie, you don't you don't know my name and that sort of thing. Are you thinking about me in different ways, right? And so I came to this place, to this clinic. I had some chronic knee pain, as you alluded to, and it was really amazing because it was like, yeah, no eye contact, don't examine the knee. And it's like he saw me, he saw I could walk and sit and stand. It's like, okay, well, you're okay. But he didn't know anything about me as a person or what kind of job I had or how knee pain might impact me in any way. And then, so I'm not a person who just sort of does the whole I'm a doctor person. I don't wear that on my forehead or sleeve normally. I guess I do today with the white coat, but but normally I don't do that, not in everyday life. And so, um, yeah, it was striking. I mean, I feel like I had to do that because I knew that some things he wasn't doing were things he needed to have done. Um, and it was like, wow, you know. And so, it's just a striking illustration of how differently you could be perceived in different ways. I mean, a lot of us have had that sort of experience in different ways. Like, I might be in the med school one day. Like, there are other things that even I talk about the book, and then I go out into town, and people see me differently. There was a story I had that didn't get in the book. I didn't put in the book, but it was one story where I was leaving um, as a medical student, leaving the hospital, and I got pulled over, a law enforcement officer, and then he immediately accused me of having drugs and a gun on me, and it was like, wow,
Mm,
it was like really striking, and I had to like have this flash my medical school ID badge to sort of validate my,
right.
role in the world, so these kind of experiences, I mean, I'm not unique in this way. um, I think what it means for providers, though, I guess, to take this to circle back to the point I'm trying to make. I think
Mhm.
it's important for us sometimes, if people are different from us, um, or like for me, you can't tell here in this video in box, but I'm a really tall person, extremely tall. So a lot of times, when I was younger, that might mean, well, do you play basketball? I get that every
Right.
single day of my life. But at other times, as a younger person, it might be a perception of threat. People might sort of
Mhm.
be wary of me, given my appearance. And so I think what happens is we have to sort of think, well, what are we bringing into this thing? And so if a person makes you uncomfortable, which often happens in all sorts of settings, it doesn't have to be race, it could be different things. Our natural tendency is to kind of rush through that encounter, is to sort of
Mhm.
push through things. Let me get this thing done so I can get out of here to the next person. So the discomfort could be, do you think this person's going to be a quote unquote complainer? The discomfort
Mhm.
could be that this person is someone you think is going to get agitated or upset. Discomfort could be a language thing, or it could be a million things that could be discomfort with. It could be based on your own
Mhm.
sort of bias. The point I'm trying to make here is that our tendency is to rush through things. And so what I learned in that encounter, but also in general, is that really we should really slow things down a little bit. Obviously, if there's a immediate safety concern, that's a different story. But generally, if our impulse is to say, well, I don't want to be just deal with this person, I'm going to get out of the room and give them a prescription for something they don't need or whatever.
Mhm.
That's where things happen that are problematic, actually. So I think that's where we run into a lot of encounters. So I tell trainees, when your impulse is to sort of rush out, that's when you probably should slow down. And so the people that you feel like people, because one of the things that we found in clinical practice is that, particularly in psychiatry and other fields, a lot of times these cross-racial clinical encounters, you might actually need more time with the person to unpack the differences that you already have. But what happens in practice is that these visits are often shorter. And so
Okay.
they did some study years ago, and I mentioned in the book, but like psychotherapy encounters with black patients and white providers, and those encounters were shorter. Um, and so and again, I think it's a lot of that kind of sense of probably patient and provider discomfort with one another. But we have to sort of find a way to work through that and be able to but the starting point to do that is acknowledge that we might potentially have that shortcoming, or we might have
Right.
this blind spot that we might have.
Mhm.
And I think the more we can kind of grasp and hold on to that, the more we can know. Like there's certain types of patients that, I have a little more of a, so that I kind of go into knowing, okay, I have to slow this thing down before, so I don't mess up. So I
Right.
think that's an important lesson to learn.
Right. Thank you. Thank you very much for that insight. Moving to the next chapter, you talked about in chapter 7, you discussed the HIV/AIDS epidemic of the 80s and 90s and the role that race played. What parallel, because we are in 2022,
Right.
as the year is coming to an end, and we're almost a full 2 years into the global pandemic of COVID-19.
More than 2 years.
Almost, right, you're right, more than 2 years. What parallel can we draw to HIV/AIDS epidemic at the time and the COVID-19 pandemic regarding race, and what lessons have we learned or not learned?
Yeah, so certainly one lesson we didn't learn, obviously, is an adequate infrastructure to support public health enterprise in the broadest sense, right? So that's just been like we don't really have it again. Like when you say we don't have a healthcare system, it showed we really have some tremendous flaws in our sort of public health system. Distrust, but not distrust, but just the infrastructure to actually make things happen in the way that they need to happen was glaringly obvious in so many ways because of that lack of investment. Um, when you think about the role of government, you think about isn't the role of government even more than anything else is to sort of like to protect people? Like if you think of anything else, right? This is sort of and certainly are we considering public health part of that protection of people? And certainly we should. And I think that's the debate that we've been sort of wrestling with these last couple of years. So one of the lessons that I think comparing the paralleling HIV to COVID is how quickly diseases can be stigmatized, right? How quickly we can sort of go into this realm of like oh, only these certain people get it, and these people get it, and they get it because they're this kind of person or that kind of person. So I think there's that's the part that's so easy for humans to do. I say another obvious parallel is that when you think about realm of disparities, is that of course, um, well, actually, in the early part of HIV, it wasn't as clear that it was racial disparity was harming
Mhm.
African American people. That became something that's evolved over time, and
Right.
and that's been a larger function of again a lot of these larger social structural factors, right? Access to care and everything else that goes with it. So with COVID, of course, in the early period, we saw these racial disparities play out pretty early, and again, it's just a reminder of how much of health is there's a small portion, of course, that involves health care and the delivery of medicine, but then
Mhm.
how much of it sort of takes place outside of that. And so I think both pandemics really illustrate that reality. It also illustrates um, how difficult it is. How easily mistrust and rumors and misinformation can spread. That's
Mhm.
worse now, I would say. That's worse now than it was. Although there was tremendous misinformation even during the era of the AIDS epidemic. There was tremendous misinformation about how you could get it and everything like that.
Mhm.
But now it seems like we should be at a more advanced place, but certainly does in some ways it feels like we're not when it comes to the spread of misinformation.
Right. Thank you for that. We had a follow-up question from someone from the audience, and again, I want to encourage folks that if you would like to ask a question, you can feel free to put that in the chat. A question from the audience asked, with your background in mental health, what are you seeing with regards to your colleagues and their mental health and
hmm
resiliency
hmm
given the healthcare response to COVID?
Yeah, there's been a lot of discussion about that, right? There's been a lot of talk about provider burnout, and that's been an issue that's been there for a while. It's certainly got accelerated the last couple of years. I know there was that unfortunate story, the ER doctor in New York, I believe, who killed, died by suicide, and there's I think it's called Lauren Breen Act or something. So it was a congressional sort of act related to that. So it'll be years before we know what that congressional thing's gonna do for actually in terms of helping providers. There's no doubt there's tremendous burnout. The amount of workload has just, even I can see personally, has gone up so much these last couple years. So for the first few months, things really sort of cratered, and then it just went up, and then it hasn't stopped. Um, and it's yes. So there's no doubt about that. The question about healthcare providers and what are we doing about that? That's one of the things that I think is an issue that I talk about in my book. So one of the things I know I'm not talking here to talk about the second book, but I want to just preview it in a way because one of the things I feel like our approach to mental health and our longstanding sort of way in which we've kind of sidelined that mental health issues among ourselves and society and patients we see has not only harmed the patients who come to the hospitals and clinics, but it actually has harmed the providers themselves. And
Mhm.
so I think because of our unwillingness to give you a couple examples, so this is starting to change, but for many years, medical societies would ask if if you had any history of mental health issues, and you'd have to disclose all this, whereas you wouldn't have to do that for other sort of quote unquote medical issues. And it did it in a way in which people, so it actually just would discourage people from disclosing or seeking mental health care because they were afraid that this would then be used against them when they try to renew their license and these sorts of things. So
Right.
again, that's been something that's been a more recent change. So I would say that trying to take steps in the right direction. There's been some concerted efforts to do that, but we're way behind. And there's no doubt that the last 2 years, um, in so many ways, have escalated the urgency and the need for mental health care. Um, yeah, so I'll just leave it there.
Thank you. Thank you for that. And I appreciate the folks that are dropping their questions in the chat. Again, remind you to put your questions in the chat and we will get to them. In the book, you provided examples of discrimination as practiced by doctors.
hmm
What are some of the more common ways in which this manifests itself? Do you think it's overt or more subtle regarding discrimination practiced by by doctors?
It's probably going to mean, so it can happen at all different levels, right? So there's discrimination, there's racial discrimination you'll see, there's sort of like different discrimination by language, like if their primary language is in English, there's all kinds of discrimination that sort of unfolds there. For years, hospitals in medical settings didn't have interpreters, and they would use, like, they rely on like family members, sometimes children, to be the interpreter, and that's really kind of not ideal. Of course, there's gender and all, there's no doubt. Issues around sexual orientation. I've seen so many different things. So some of those things, I would say this. So as it's sort of mirroring society. So racial discrimination has been, so the overt racial discrimination is less so over time, right? It becomes more subtle, right? Much more subtle. So you're much more likely to see things that are more subtle. So a provider might be, and some of this intertwined with class. So like at a certain clinic, providers might approach patients differently than they might in another way in terms of their expectations of what the patients can do. And as a chapter in the book, I talk about that, where the providers were surprised that this one guy, he's in this sort of public kind of lower income clinic. He has a lot of knowledge about managing, diet and nutrition, and they sort of are taken aback and they start to like judge him in some sort of strange way, which I know they wouldn't have done if they'd been in this sort of more well-to-do setting where they would have probably had an expectation he would have had that level of knowledge. So I think sometimes providers might offer less options to patients because there's a sense that they think the person can't do this or can't do that. Some that's a provider, some that's a system that they work in. Patient with certain insurance can get some care, patient other insurance in private pay can get different kind of care, right? So there's different things that are sort of intersecting at the same time. In terms of things like gender, particularly sexual orientation, I've seen some really horrendous, blatant sort of thing, like blatant discrimination. Things that when I was, 10 years ago or so, things that I'm not sure if they'd fly now, but there were some really awful things that you would see said and heard. So I think those things are probably less likely to happen now, but those are more recent vintage. Whereas racial discrimination has certainly been present throughout, but it's more likely to be subtle and often the times it's tricky because patients wonder, they're like, man, was this guy doing this because I was black or not? So a lot of times it's really tricky. You don't even know, and sometimes that can really be one of the hard parts. It's almost more clear if they just tell you up front and you just kind of know. Okay, so I know what I'm dealing with, and so it can make it even more challenging for patients if they don't really know.
Yeah. So in that same vein, what advice do you have for healthcare professionals to prevent medically prejudiced or racist practices?
Yeah, I think it's really more about just sort of, it starts with yourself and understanding kind of your own limitations and being able to sort of privately kind of understand what might be your own limitations, and doing an exploration of yourself, an inventory of yourself. I think one of the challenges that we have in this society is that people sort of have this either or, and I'm not sure how helpful it is and people are afraid to be labeled one thing or and it's like you're either good or you're bad. And I think we do too much of that kind of stuff. I think people are much more complex. And I think if we can sort of have the space to sort of accept, okay, geez, I really might need it. This is kind of really not so great attitude, or maybe even embrace the idea that like, look, my parents did a good job of raising me in this way, but man, maybe they were, kind of a little backwards on this sort of thing, and to be able to kind of hold these two things together at the same time, it allows us to be able to look at ourselves in a more forward-thinking, productive way. Like we're never going to be perfect, but we can certainly do a lot better. So I think the more we can sort of not be defensive and resistant to this idea that we could do better. I'll give you one example quickly. So years ago, I wrote a note in a chart, and one of the providers, one of the colleagues said, well, it turns out in this particular case, the guy was gay, and then the provider, but I guess I provided some details. I don't remember the specifics now, but I provided some details in the chart that one of the other providers questioned, said, well, why did you what was that? What did you do that for? Like, why'd you do that? Right. And I could have gotten defensive, right, and said, oh, what are you trying to accuse me of, and blah, blah, blah. But it was an opportunity for me to think, why did I do that? And what kind of things had I internalized, and how might that be problematic for the patient, right? And so I think that kind of sense of inventory and that ability to sort of have people that you trust be able to sort of talk with you in that sort of way and to be receptive to that versus defensive, I think is the key.
Thank you. Thank you for that. We've got a question in the chat. They mentioned, thank you for your insight, Dr. Tweedy. They have yet to read your book, but they have purchased it and look forward to reading it. So they asked, to your knowledge, is implicit bias now being addressed in the medical school curriculum and the classroom? And what policies or interventions would you suggest to reduce implicit bias leading to poor medical treatment to mitigate disparate outcomes for racial and ethnic groups.
I think some of that's happening for sure. So many schools nowadays have all. It comes under different titles, different names. But many medical schools now and other professional schools have different types of coursework that is required and baked into their sort of curriculum, where they talk about these topics. They talk about disparities. They talk about implicit bias, and so there's more discussion about. One of the challenges with that, though, I think two things. One is that if you only limit it to a single course, it makes you think that maybe it's not as important. We're just trying to check a box. So I think that's one concern. So I think it has to be sort of woven throughout the entire medical education, professional curriculum. So that's one issue. I think the other issue is, gosh, I lost my train of thought there. I hate when that happens. That's one issue. I think the other issue is, it's not. It'll come back to me. I'm sorry. Give me some time to come back to me.
Not a problem. We'll come back to that. We have another question in the chat.
Oh, no. I just got it. I knew what happened. So the other challenge is so if you have the classroom learning, but there's two types of learning and training. There's classroom learning, and then there's actually practice on the job learning. And so what kind of method, they call it the hidden curriculum or the informal curricular, and what are you actually learning from the people? So you can learn all you want in the classroom, but then if you go into the hospital and the doctor who's supervising you and giving you grades says that stuff's not important, you got a problem, right? And so there's certainly been an issue that's happened historically with that sort of limitation. So what I would say to that is, one is I think we need to continuously reevaluate who are the people who are teaching our people coming up, right? And I think there's more effort and attention being paid on that now. Just because someone was once seen as good or as funny or whatever doesn't necessarily mean that they're the appropriate person to be, teaching students. I think there's been much more attention paid to that. And I think, of course, now with more students coming to the field, knowledgeable about these areas, I think that's going to, over time, that's going to really open things up, and you'll have many more sort of what you might call culturally, what's the word, humility in terms of their care to patients.
Yeah. Well, thank you for that, and for coming back to that answer. We have another question from the chat. Outside of healthcare professionals, who are the community-based advocates needed to help change this narrative?
Yeah.
And what part does the patient play?
Oh, well, patient plays a huge part, obviously. I think the one thing I would say with patients is sometimes there's a sense of we need to sort of empower patients more, and patients need to empower themselves more, of course, as well, because I see a lot of times patients are really passive in terms of things, and whether it's having a provider they're not comfortable with, but sort of still kind of going along with things, and maybe not asking the questions they probably should ask, like like how would you do this if this was someone that was close to you, or these sorts of questions that you might want to ask someone. I think another way that patient empowerment is often to bring someone with you, because a lot of times if you're having a health issue, it's a lot of fear, right? You come into that space and it can be overwhelming, and you might want to ask questions and just don't remember because you get flooded with stuff. And so having someone who's there, so writing stuff down before you come in, is really important, so you don't forget stuff. But then maybe having an advocate for you who can advocate for you as well. I think those are really important things for people to do from the patient standpoint. There's also, some people call them peer support people or patient navigators, people from the community who help people navigate the healthcare system. I think those are really important. I think we need more investment in that, to be honest with you, and more structure, but also more investment with those things. Other ways the community people can help. So I think about the intersection of, you mentioned about religion, right? And so I think that's really important for a lot of people, obviously. And so one thing, so you think about psychiatry, it's historically been, those two things have historically been at odds. Psychiatry and mental health. Psychiatry and religion have all historically been at odds often, where one is, trying to explain the world, and, it's like a competing sort of thing. But once again, there's ways in which we can, make things better. So I think about my own personal experience when I was thinking about psychiatry. I had family members say, well, why would in the world would somebody go to a strange person they don't know and share all their life story? It doesn't make any sense to me at all. A lot of people in my family would say that, very close to me, actually. And but they would say talking to a pastor would be something they would do, right? Because there's a sense of connection that they would have in sort of framing the world. So there's been places, there's been programs kind of all over that are starting to pilot this idea. Some are much further along that, of how do we integrate the faith communities and the medical communities around mental health, and having, sort of bi-directional relationships. So like I've seen it work both ways, where we get referrals from people in the faith communities So someone's come to their pastor, the pastor's got some more education from mental health from our standpoint, and they bring people into our world, but also the other way. So there's so many times where we see people who are deemed as having quote unquote mental health problems, and but so many times, so many things can be really addressed in a sort of through the framework of their, of their religious beliefs,
Right.
outlook on life. And so I think the bi-directional sort of relationship versus it being siloed is one great example within mental health, which we're seeing more and more of. It needs to be scaled up. But these are things we're certainly seeing it coming across different communities, which I think. So I don't know what maybe you have some of that in your community as well, but we're certainly seeing that more in our own institution. Like so, a place like Duke is partnering with local communities in Durham with certain pastors, and so we're having this sort of good relationship in that way.
Thank you for that. And so you talked for a moment about investment. So I kind of want to ask this particular question. We have Meharry Medical School here in the state of Tennessee.
Hmm.
Why is it important to have more Black physicians?
Yeah, so I'm gonna do a quick detour here. So Meharry is a treasure because like so there's this report called the Flexner report. Some of you probably won't know it, but it's Flexner, and really that report is like over 100 years old, but it revamped medical education in America across the board. By over half the medical schools in America closed at the time. And it really did. It modeled the sort of structure we have today, where we have the idea of like you do basic preclinical basic science, and then you go to clinical science. It's like the whole structure. You had to have a college degree before you go to med school. It sort of led to all that stuff. But what happened? One of the unintended consequences of the Flexner report is that there were 7 historically Black medical colleges in the U.S. at the time. You may know the story already, but 5 of those schools closed, and so only 2 left were Howard and Meharry. And so from between the 1920s all the way through like the 60s when there was started widespread integration, Black people really couldn't go to medical school. It wasn't like, well, you can't go to this med school here. You could just go to the University of Tennessee or the University of North Carolina. Interestingly, you got me on this tangent here, but interestingly, several states adopted policies during that Jim Crow era where, in order they would not allow a Black student to go to med school, but they would actually pay for that student to go to Meharry or Howard. And so that was kind of what happened during that era. And so what happened is you have a generation of people who were deprived of the opportunity to get into the healthcare field in medicine, right? Because there's only 2 med schools for the whole country. And so there's been a lot of talk in the last several years about how there's so few Black physicians. There's a report that came out. One thing I was surprised when I learned is that the issues that the stories of Black men in medicine is actually the numbers have been really stagnant for a very long time. That's a larger conversation for us than we can probably navigate here. But what happens is, why is that an issue important? So I would be the only Black. So often, even to this day, like you have a whole group of doctors or medical team. I'm the only Black physician. Very common, right? You have a senior doctor, you have your residents, your students, and I'm the only person, right? And it's usually less Black in dynamics. Half the patients we see will be Black. And when I remember, even as a student, sometimes the medical teams, senior people were asking me to come talk to a patient to ensure that the treatment that they were prescribing to the person was the appropriate treatment, because the patient didn't believe him. They thought that this particular medicine for diabetes or this particular recommendation for dialysis was a function of them trying to like hurt them in some way. Can't tell you how many times I would see that, and I would have to kind of translate and assure the patient that this was the appropriate care. And so it really just underscores the profound disconnect that sort of historically we've had. And so that's one logical area. Another time when I got to psychiatry training, half our patients in our clinic were Black when I was a resident. I was the only Black person out like a dozen providers, psychiatrists, and I had like so many more patients than everyone else. But I'm just a trainee myself, and so it was a sense of me trying to like meet this large need that one person can't meet, right? You speak about burnout. I think there's a large, I think a lot of the burnout you see among Black providers in particular stems from this idea of like being responsible for taking care of this whole community of people, and you're just one person, but you're also dealing with your own struggles. And so there's a lot of those challenges are very real, and we see in practice as far as the burnout issue goes. So I think it's really important. So I think it's important. Again, I'm not saying we need to have segregated medicine, but I think we do have to recognize our history. We do have to recognize that in certain areas of medicine, maybe it's not important in one field for a patient. Maybe they don't care who the doctor is who does whatever, but they care about this other particular specialty. They care about their OB/GYN, or they care about their pediatrician, or whatever. It's really important to have those choices, the array of choices. To give you an example, in another setting, you think about women in medicine and women patients, women in gynecology. So when I was in med school, um, it's probably, a lot of it was still quite a few male gynecologists. There's much less now, but there's still some. And I guess one of the things I would say is that, some women don't mind. They don't care whether it's a male or female, right? But some women it's really important, right? And so to have that choice is extremely important. Similar in psychiatry, there's some women who really want to see a woman therapist or provider because they've had some sort of, emotional trauma by their father, their husband, or whatever, ex-husband. And so, I think it's really important for us to think about these things. And so having the choice for people who need it is really important. Otherwise, people will fall through the cracks. There's no doubt about that. It's not the answer to everything, but it is
Right.
one part of the larger puzzle we need to address.
Yeah, absolutely. So thank you for answering that question. I know that several folks had that question and submitted that to us. So if we come to the final 10 minutes or so of the conversation, I do want to remind everyone about Dr. Tweedy's book, The Black Man in a White Coat, A Doctor's Reflection on Race and Medicine. If you've not yet picked it up, I strongly encourage you to do so. It's a very easy read. You'll walk away with so many nuggets outside of just this conversation that we've had today. I thoroughly enjoyed it myself. So I have a couple other questions. Again, as a reminder, before we get to those couple of questions, if you would like to join the Health Disparities Task Force, we encourage you to send us an email at tdh.ofbce@tn.gov. Learn more about the work that we're doing at the Tennessee Department of Health as far as health equity and health disparities by going to our website, which is healthdisparities.tn.com. So in the last two questions, first is, what is the most promising change you have seen in your many years in practice?
Uh, I'd say a couple things. I think one is again, the type of students who are in health professions who are entering the field is very different than what it was when I was a student. And so it's not just a function that they're young and young people bring more energy. I think there was a very much a sense of much more sense of like corporate or kind of, just sort of how much we can get out of being a doctors in terms of our own sort of personal gratification and things and that sort of thing. I think it's much less of that and much more students with a sense of activism that are entering to the field. I think that's really important for us because if you can't bring those questions onto the table, you can't really begin to change things. So I think that's really been a promising thing. I'm slowly being encouraged by there's slowly being a greater embrace of the role of mental health issues. It's this idea that we have a brain and we have a body and somehow they're separate. And it's like, it never really makes sense, but we've so much of it, we've embraced that idea. The more that we're trying to integrate those two things, the better we're going to do for healthcare delivery. I think sometimes some of the FQHCs have been a little bit ahead of this game in terms of how do we literally integrate mental health providers in medical settings. So I think I'm encouraged to see more and more of that. That's something that really needs to be scaled up, but I'm encouraged to see more and more of that. Those are probably the two things I would say that that were there. One point I do want to say though, I guess I don't know if I should make this. I mean, I'll just say it now in case we don't have time later. I think it's easy to be discouraged about a lot of stuff. If we're honest, right? There's so many things that happen. It feels like sometimes there's like a lot of perpetual backlash. You make a couple steps forward, you take steps backwards. Maybe you take two steps forward and you go back 1.5 steps. There's a lot of that sort of feeling among the world. I think sometimes, there's not that there's nothing to that, but I think that we have to sometimes think about the larger scale of history. So this country, what, 400 years kind of thing. For 350 years ago, it was like systematic oppression.
Yeah.
So that's still 70. That's like 85% of 90% of the country's history that was mired in that way. You think about where we've kind of, progress of course, has been uneven, and there's always people who are going to try and push back. But the life expectancy differences. I thought about like when Dr. King. There's that quote he made about all the forms of inequality and justice and health. It's the most shocking, right? So in his time, the life expectancy difference in states like Tennessee, North Carolina, Georgia. I went back and looked at the data. You go back and look at like 1950, 1960. We're talking like 8 or 9 year difference. Among black men versus white men, black women. Some of the states with black women and white women, there's like 10 or 11 years difference. I mean, that's like a whole decade of life. Now that gap's not completely gone. It may be, but it's been cut down like 3 or 4 years. Again, that's not great. We're not saying we should stop working, but it does show that stuff that we've done has made some progress, has made some difference. So, I think I do want to push back on people who say that nothing has gotten better, because I also think about like, and again, a lot needs to get better. I'm not going to lie here and pretend otherwise. But I think about when my dad was coming along, my parents grew up in segregation. Duke was segregated. He couldn't have gone to Duke. He couldn't have gone to UNC, University of Virginia. Those places would have barred him from coming there literally by law. And so, I think we have to understand that arc of history. We can't get complacent though, because we know that there will always be a longer term battle. But the final point I would say to that is though, is that rather than use that as a form of discouragement, I think it's in some ways it can be a sense that, we know there's so much to do. So how do we pair what we're passionate about personally? Because almost anything we can do to make things better. So how do we pair what we find personally gratifying with this larger mission? So for me, I enjoy writing, and so writing and advocacy goes together. Some people it might be, well, I enjoy this particular type of surgery or whatever. Whatever it is that you enjoy, there's opportunity for you to sort of pair that passion, education, whatever. So I would say that the opportunities are limitless, right? You find what whether you're in communications, you're in media, right? So whatever you find is your passion, you can pair that with this desire to sort of improve the world in a larger way. And so my charge for like the students, I always tell them, how do you find a way to leave this space, a little bit better than how you inherited it, right? And so that's sort of how I see it. Like when I came into medicine, again, we didn't talk about this topic at all. So how can I leave this space better by us talking about it? And then maybe you guys can come with some even solutions to sort of, move it forward beyond anything that I could do. And so that's sort of how I see the larger sort of arc.
Well, I thank you for that answer. You kind of got into my last question, which was what can readers or what should readers take away from your book? Do you have any final words in 30 seconds or so? What should readers, as they read Black Man in a White Coat, what should they take away from this book?
I think, one is they can understand a little bit of so if they're providers or they're taking care of community, maybe they can understand some of the complexities, right? There's not just social complexities, there's psychological complexities to experiencing racism and how that impacts your sense of self in a way that you can sort of navigate the world. And the more you can kind of understand that, the more you can understand communities and individual behavior that you might find you might have a hard time understanding. So the more you can sort of understand those things, I think the more you can sort of can do that. I think it's also an invitation for people to look at themselves and look inwardly and to think about where are my blind spots? What am I missing? What might I do better? It's easy to go back and look at the past and say, oh, these people were bad. It's easy to do that. It's easy to look at people that we disagree with now and say that they're bad. But that doesn't mean that we're perfect, that we're not doing things ourselves that could be wrong. And so I think it's an invitation for us to think about our own sort of lives and our own struggles and how we can sort of, again, leave the world better than how we started it.
What a wonderful way to not only end this conversation today, but to end our Health Equity book series. Thank you very much, Dr. Tweedy. We really appreciate you coming on and talking with us. We're getting some hand claps that are coming through as well. Really appreciate you coming on and talking to the state of Tennessee and all of our Health Disparities Task Force members and many others who have joined us from across the country. We really appreciate this time with you. Again, to learn more about Dr. Tweedy and his book and to watch this replay or to watch the replay of all the other conversations that we've had with this Health Equity book series, we encourage you to go to healthdisparitiestn.com. Stay tuned for our next series. Thank you so much, everyone. Bye-bye.
And a clap to all of you as well.